be, I won't be able to see you all, so um, please feel free to interrupt, but I won't
We'll
like, I don't,
monitor the chat, Jessica, or people should just come off mic and interrupt you as they need. Yeah,
awesome. Yeah,
great.
terrific. And do feel free to interrupt. Um, and let me just keep track of time. Okay. S- And one more question. So, Brig, when do I want to aim to be finished? Ish.
I would say maybe like 5 minutes before the hour.
Okay.
So yeah, just a few minutes for questions.
Okay, perfect.
Thank you.
Yeah, thank you. Okay, so I'm going to talk about medications to treat opioid use disorder in the era of fentanyl. I am not going to do an overview of the neurobio of addiction. I do think it will be helpful to review methadone as treatment and then the office-based medications to treat opioid use disorder. And then we can um, be sure to discuss sort of well, most of this is about the distress around getting started. So hopefully we can really dig into that. And just to be clear, like, yeah, what about methamphetamine and alcohol and cigarettes and sugar and, I mean, there's a million things we could talk about when we're talking about substance use disorders. So why this? Why opioid use disorder? Suddenly I'm not advancing. Oh, there. Um, it's really because the mortality has just skyrocketed and the rate of increase for American Indian, Alaska Native communities is much greater than the rate of increase than for other communities. So the AIA and opioid overdose death mortality increased 161% from 2018 to 2021, and that's compared with the 59% increase in white populations and 143% increase in the Black populations. Horrifying for every population, and AIAN have really, it has been truly devastating. So that's why the focus on this today. Okay, so let me just do some skipping. Okay, so let's talk about methadone first. So a brief review of the pharmacotherapy for opioid use disorder, because I'm going to talk about methadone and buprenorphine. Um, Methadone is a full agonist. So what that means is it sits on the receptor and it activates it fully. It gives it all of its oomph. Buprenorphine is a partial agonist. That means it sits on the receptor, it activates it partially. And naltrexone, often known in its injectable form for opioid use disorder as Vivitrol, is an antagonist. That means it does not block the receptor at all. It just sits on it and doesn't let opioids in. And this is a cartoon showing that the methadone fully in that receptor and turning it on, the buprenorphine kind of turning it on, and the naltrexone not turning it on at all. So why do those medications matter now more than ever? And actually, I want to pause for a second. The reason I'm not going to talk about Vivitrol is it has no mortality benefit. The other two we know have a mortality benefit. Um, Vivitrol actually may increase overdose. There are circumstances where it's helpful, but because the other two are so important, I'm not covering extended release naltrexone. So why do they matter now more than ever? Fentanyl. So this is a picture of a bag of blues. I don't know. I think blues were big in California for a while as well. I was in Oregon when they showed up on the West Coast, and they were suddenly everywhere. So fake oxycodones that were blue and were actually fentanyl. I don't see it anymore at all. I don't see the blues. I only see powder. Um, this is a penny, and this is the amount of powder if someone is opioid naive that will kill them. Fentanyl is unbelievably potent. And this is the way it has showed up in terms of death. So the red line along the bottom there are prescription opioids um, that, a lot of us prescribers helped fuel that overdose crisis. And then the pink line, you can see right as we started cutting people off from their pain pills without any treatment, a lot of people turned to heroin. and heroin deaths started to escalate, and everyone was highly concerned, rightfully so, and then you can see the scarlet line skyrocketing, fentanyl showed up. And on the East Coast, it showed up around 2013, 14. And on the West Coast, it was later. We saw it more around, 2019. And it has been absolutely devastating. I mean, the slope of that line is virtually vertical. And that is why methadone and buprenorphine are so important. So this was a study on the BMJ in 2017 that looked at mortality risk during and after use of methadone, and they also looked at buprenorphine. So mortality risk on the left, this is all-cause mortality. So without methadone in orange, with methadone in blue, you can see the difference is dramatic, remarkable. On the right is overdose mortality. Again, orange, no methadone, blue with methadone. The difference in mortality risk is remarkable. And you see not quite as dramatic, but still quite similar reductions in mortality with buprenorphine, both all cause and overdose risk. So these medications are really quite stunning. Okay, so I'm going to talk first about methadone, which again, most providers don't have a lot of experience with because we're not allowed to, and I'll go into that. So what is methadone? It's an opioid. And what is an opioid? An opioid is a synthetic or a semi-synthetic substance that mimics opiates. So what is an opiate? An opiate is a natural substance that's derived from the poppy. So basically, for thousands of years, the poppy has been used to access the effects of opiates. So that the pod is dried. This sap is kind of seeps out. It can be scraped off and then used and smoked. It can be turned into opium. It can be turned into morphine. It can be turned into codeine or heroin, and it's been used for various purposes for thousands of years. And in the 1800s, it emerged as a popular cure-all in the US. This is a picture of Mrs. Winslow soothing syrup for children teething. And that was opium. This is Bayer's heroin and aspirin. I think for cough, they also used it for treatment of tuberculosis and anxiety. There's a couple little kids reaching for their heroin. And it became common enough that in 1914, Congress passed the Harrison Narcotics Act, and that regulated the consumption and availability of opiates. And as part of that act, it said that a doctor could still prescribe opiates, but in the course of his professional practice only. So what that meant in that context, and at that time, substance use disorders weren't considered part of the medical domain. So you couldn't prescribe an opiate to treat a substance use disorder, to treat an opioid use disorder. You could use it to treat pain, but doctors were not allowed, or other APPs were not allowed to prescribe opiates to treat opioid use disorder. So that was 1914. Then fast forward 60 years, and it's the Vietnam War. And estimates are that 10 to 25% of military personnel were using heroin. And there was also just a lot of heroin use in general in the United States. It had been increasing, which was quite concerning to the president at that time, who was afraid that he would be blamed for it all as he was coming up for re-election. And potentially he also really cared. But the part of it was that he was concerned about his re-election, and he did declare the first war on drugs. And as part of the war on drugs, he worked with or identified Vincent Dole and Marie Neiswinder, who were researchers at the Rockefeller Center. And they had found that research participants, they'd been studying this drug called methadone, and they found that when they gave methadone to research participants, those participants used a lot less heroin, which was quite thrilling to Nixon to find out. So as a part of that, in 1970, the FDA in the Nixon administration approved methadone for detoxification. 3 years later, it was approved as a maintenance treatment. So originally you could start it, but only tapering immediately off. Then in 1973, people could stay on it. But again, doctors weren't allowed to prescribe it. So we had this medication, but no way for people to access it other than through these research protocols. But in 1974, opioid treatment programs were created. So methadone clinics to dispense methadone. So again, medical providers still unable to prescribe it for OUD, but now there's a place where methadone is available for people with OUD. And it was really, really helpful. This is a Cochrane review from 2009, and there have been so many studies of methadone. I don't think they do them anymore because it's just sort of a done deal. But study after study has found that patients taking methadone are less likely to have a positive urine drug screen, fewer new infections with hepatitis C or HIV. Communities that have methadone clinics have decreased criminality, and there are definitely decreased deaths. It's so important that it's on the World Health Organization's list of essential medications. But again, this all of this was part uh, of a federal program. This isn't a clinical program. This is a federal program. And so a lot of regulations were created around methadone that don't really have anything to do with a clinical evidence base. They were created as part of the war on drugs. So a very different perspective. So when the OTPs, the methadone clinics were created, they were highly regulated. In order to receive methadone, a patient had to show up at the clinic. So there's no getting the prescription, right? And for the first 3 months, that meant coming to the clinic every day. After 90 days, a person could take home 1 dose if they had been attending all of their groups, if they could show that they had been participating in educational or vocational or homemaking activities, and that those activities would be hindered by attendance, and if they weren't using anything. So that would include opiates, marijuana, methamphetamine, anything, alcohol. So no substance use whatsoever. Tobacco was okay. No criminal activity. If they could show that they had a stable home environment, so if someone did not have housing, they could not get take homes. If they could store it safely in their home environment. And then if their counselor, and often these counselors had huge caseloads, felt that it would be beneficial to the patient. So they had to meet all of those criteria to get one take home. And for the rest of the week, they had to show up every day to get this life-saving medication, which resulted in long lines at methadone clinics. So if all of the patients who need a medication have to show up, or most of the patients who need a medication have to show up every day, you're going to get a real backlog of patients. And most of these clinics are not sort of spacious, beautiful clinical settings. At least the ones that I've worked in are pretty cramped, and they're usually on the crappier side of town. And so there's not a lot of space inside, not nice lobbies for waiting. So there are a lot of long lines. And a lot of long lines in parking lots and around the block. And as Sam Quinones, who wrote Dreamland, wrote about, it's a perfect place if you're a dealer. Um, you've got a bunch of people outside, either in a parking lot or around a block, who are in early recovery or not yet in recovery, and who are withdrawing and craving. So if I'm an opioid dealer, like that's my go-to place. That's gold for me. And dealers also discovered, not just the opiates, but also the illicit benzos, these crazy designer benzos that are quite deadly, have found their way to the methadone clinics as well, along with methamphetamine, et cetera. So it's a real scene, or it can be a real scene. It isn't always. Um, and as a result, communities didn't want them. So here's a sign of a guy protesting, didn't want a methadone clinic in his community. This sign says, "Don't let that methadone clinic kill our community." Here's a community victorious in shutting down their clinic. And again, this is a life-saving medication for people with opioid use disorder. And as a result, both of the stigma attached to methadone clinics, the scene that often results as a result of the structure of methadone clinics, and as a result of them just being really hard to open because of all the regulations. There's just so many hoops to jump through. Fewer than 20% of US counties have an OTP. So that's remarkable if you think about it. And I forget which state, but some states don't have them either. I think it might be West Virginia, but I'm not sure about that. And only 4% of OTPs are in rural areas. So residents of rural areas have to drive sometimes for hours to access the medication. And as you might imagine, this can be a huge deal in Indian country. So 4% of OTPs in rural areas. So if you are someone using fentanyl who really needs methadone, you're either just completely out of luck, or you have to center your entire life around getting to the clinic and getting back. So COVID did change some of this. As a result, so COVID hits and people realize that these OTP lobbies are crowded and there are these long lines and they're a little bit chaotic sometimes. And so SAMHSA issued an emergency exemption to the OTP regulations in March 2020. And those exemptions said that states could request blanket permission for stable OTP patients to receive 28 days of take-home doses. So they could basically get a month to take home if they're stable, or up to 14 days of take-home doses if they're not totally stable, but could handle the administration safely. And the definition of stable or less stable was left up to the discretion of the OTP medical staff. And they also allowed for the first time telehealth counseling. So another component of the OTPs is required counseling. And if you remember, to get a take home, you had to attend all of your counseling. But again, if the clinic is hours away, making it to every counseling session, plus making it to get your medication, plus having to drive hours, it was really tremendously difficult. So suddenly telehealth was available, and so people could potentially attend these required counseling sessions more easily. So the result, first, and I do have to acknowledge these are really hard studies to do, but so as far as these studies could tell, rates of diversion of methadone did not increase with these flexibilities, nor did overdoses. So people were not taking their methadone home and overdosing on it. And qualitative studies of the patients and staff, high satisfaction with these changes. And in particular, patients reported increased attendance to other important aspects of their lives. Like they could suddenly get and keep jobs. They could go to school. They could be there for their families. So really, really important consequence of these changes. And so wonderful that researchers saw this natural experiment happening and sort of jumped on it and said, what will be the result of these changes? And they discovered really positive results. So as a result of those studies, in April 2024, SAMHSA updated the rules to take into account both the data from the COVID changes and just the continued impact of fentanyl and the need for greater access to methadone, as more and more people were saying that they weren't getting enough relief with buprenorphine. So among those changes, SAMHSA extended the take-home doses. So now the number of take-homes allowed are much greater for patients early in treatment. So within the first 14 days, a patient can take up to 7 days of medication at home. And I just have to remind, I know it's an opiate, it's a powerful, potent medication, but there is no other medication where we would be like, wow, you can get 7 days of your medication. Like this is so dramatic and it's crazy. So, but anyway, so 7 days. When I was first working in the OTPs before COVID, the most you could give someone as an initial dose was 30 milligrams. And that's a low dose regardless, but particularly with fentanyl. So the initial dose has increased to 50, the possibility of 50. And the final rule also specifies that the presence of other drugs detected on urine drug screening does not necessarily limit take-home medications. So just because somebody's smoking pot, that doesn't mean that they can't. Methadone doesn't decrease your desire for marijuana or cannabis. So there was a disconnect there. Why would you keep someone from taking their medication because they're using a drug that the medication doesn't address? Similarly with methamphetamine. And certainly neither of those drugs increases the risk of overdose. So it didn't make sense that it would limit people's take-home medications. So anyway, so those were taken away, or the possibility that it is now possible for OTPs to allow those flexibilities. But whether those flexibilities are adopted is up to each state, clinic, and tribe. So not every state has adopted those flexibilities. Not every clinic has adopted those flexibilities, and not every tribally owned OTP has adopted those flexibilities. So it's important to remember that. And those flexibilities are great, but they haven't created new OTPs. So rural areas still have very few OTPs. And methadone access, again, although those flexibilities are great, methadone access is still restricted to OTPs. So if you live someplace where there is no OTP, you cannot get methadone, or you have to structure your entire life around it. And the reason I think all of this is really important to understand is there is so much stigma around methadone, and it is life-saving, and access is limited, and it is improving, but it is terrible. So, consider lobbying your state or your clinic or your tribe to adopt the flexibilities if you're aware of where your state, clinic, or tribe stands with regard to those. And I think also just it's important to understand the lengths that patients have to go to get this life-saving medication. That it has so much stigma, and for whatever reason, um, so often our patients are treated as if taking methadone is the same as taking fentanyl or using heroin, and it's not. It's a medication, and they're struggling really, really hard to get it. And to the question about, and we can talk about this more later, you know, I understand that. So I understand when methadone clinics might decrease a patient's methadone dose if they're drinking heavily. Um, but drinking, period, doesn't necessarily mean that someone's risk of overdose is increased, like just social drinking. Um, and it shouldn't mean that they should be denied take homes. And it definitely should not be. I think the question was like, I think the scenario was that someone had been discharged from a methadone clinic for drinking. And that just makes no sense. Methadone does not address alcohol craving. So by
Yeah, that
discharging
was
someone, yeah, sorry, go ahead.
sorry. That was my question because one being from the Native community and like
Yeah,
working with the Native community, there's like there's usually multi-substance use disorder,
yeah.
especially like with heroin, sometimes meth, and alcohol. So, sometimes I think that if methadone is a life-saving, medication for a lot of patients, that there have been so many strict rules that a lot of times these patients they get discharged and they go back to using because they're craving whatever it is, heroin or
Mhm.
fentanyl. And I know in my community where I'm from, there's been such a huge fentanyl problem. The nearest methadone clinic is over an hour
Oh,
away. And anyway, so I really think these are like things that need to be taught to like to the methadone provider, whoever it is, or you're right. I mean, lobbying on the behalf of like rural clinics and tribal health clinics.
yeah, and the other thing I would say is to be even a medical director at a methadone clinic, um, you just have to have an MD. Like you don't have to know anything about addiction. You don't have to. Uh, I mean, it is super highly regulated in terms of punitive effects. But in terms of the science, it's not regulated at all. And it's just devastating. So I think, I think it does, if 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 one is willing, it does make sense sometimes to call the OTP if a patient is being discharged for actually for use of anything. Like if they're still using fentanyl, that means increase. I've had this discussion with directors at OTPs who have said, they're still using fentanyl, so we're thinking about discharging them. Well, no, you should do the opposite. You should increase their methadone dose. That's crazy talk. So, so I wouldn't assume always or ever that the practitioners working at a methadone clinic have actually been trained in the evidence around methadone. And that's not to say that some are incredible, some are unbelievable, advocates and clinicians. So I don't want to sort of say nobody at all. Like there's some really great OTPs and really great OTP doctors, but but it's not required. So if you're concerned about something that's happening at an OTP, you're probably right.
Yeah. And I sometimes like I think that it just as a clinician working in an underserved community that is high risk, that like we really
Yeah.
need more training on harm reduction
Yeah,
versus an all over like an end approach. It's really harm reduction a lot of times.
absolutely. And I think, I think that um I think you're right. And I think that for what I because it's been so highly regulated, I think oddly enough, methadone clinics sometimes are the least open to harm reduction, when they should be the most open because they are just taking the medication keeps dramatically decreases someone's risk of dying. And so good enough. Like right there, great. Everything else is a cherry on top.
Yeah. And I do see, so I did my training in New York City. And so as a resident, I did go out to a methadone clinic in Harlem.
Hmm.
And yes, and so they're long lines. They're not usually in a very good neighborhood. Definitely in the area. If you are going through withdrawals, it can be, you have your dealers there who are standing on the corner and just waiting.
Yeah.
Yeah.
It's interesting. I don't know if there was an act, I think it's died. But it's called MODA, and I always forget what it stands for. And if anybody knows, just jump in. But it's like Modernizing Opioid Treatment. I forget what the second T is, Act. And the idea was that uh, for this act was addiction to give addiction trained providers the ability to prescribe methadone. So it didn't say like everybody's going to get it. It was really conservative, but it said, particularly in areas where there is no methadone clinic, if you have an addiction trained medical provider, they should be allowed to prescribe it.
Mhm.
And I think it passed the House and got stuck in the Senate or reverse. I don't remember, but I have a feeling it's going nowhere. But there was a lot of energy around it about a year and a half ago. Um, but I think it's just died, and I think there's enough, kerfuffle right now around so many other things that I have a feeling there's not going to be a lot of traction anytime soon. Anything else about methadone? I will say one other thing I wasn't going to talk about, but I think is important to know is there is uh and if everybody already knows this, just chime in and be like, we got it, we already know. But there's a thing called the 72-hour rule, and it is an exception in 42 CFR. And it says that any kind of prescriber can prescribe methadone for 3 days for 72 hours to alleviate I forget the exact wording, but it's to alleviate withdrawal while arranging for ongoing treatment at a OTP. And we've used it quite a bit or I did in Oregon, both in the hospital setting and outpatient withdrawal management. Um, it's really helpful, and we can talk about it more. I wasn't gonna, but we can. It can be really helpful getting people from fentanyl onto buprenorphine if you have a little bit of a full agonist like methadone. each day to help them with the withdrawal symptoms. So we could talk about that a little bit. But you are actually allowed to prescribe 3 days worth of methadone if someone is in distress and withdrawal. Or like if their methadone clinic is closed, you can actually prescribe them a day's worth or 2 or 3 days worth. The problem is that a lot of people aren't aware of that rule. So if your pharmacy's not aware of it, et cetera, you can get some pushback, but it is entirely legal.
Dr.
I
Gregg,
wasn't aware of that. Thank you.
Yeah.
just for time management, we're at quarter till the hour.
Okay, thank you. All right, I'm gonna buprenorphine. Okay, why is it so great? It also decreases opioid cravings, withdrawal, and use. Patients taking bup are more likely to engage and remain in treatment than if they're tapered. You all know this, but this figure shows if someone's maintained on bup, they're more like that's treatment retention is in orange. If they're tapered, treatment retention is in green. They're not retained. Basically, it's incredibly effective and they don't die. So to remind everyone, it's a high affinity binder at the mu receptor. So it sits tightly on the receptor. It's going to kick off other opiates that are bound there, opioids that are bound there. But it's a partial agonist, so it doesn't activate the receptor completely. And if it kicks a full agonist off the receptor, the difference between the full agonism and the partial agonism is great enough that you get precipitated withdrawal. It's also really important to know that fentanyl also has a very high affinity and high efficacy at the mu receptor. So it's got pretty much the same affinity, but it's a full agonist. Um, Single use, it's on off, but repeated use can lead to accumulation in the fat, decreased renal clearance, and desensitization at the receptor. And we'll get back to why that matters. Just as a reminder, there are 3 forms. There's Subutex, which is the monoproduct. There's Suboxone, which is buprenorphine plus naloxone. And then they're the injectables, Sublocade and Brixadi. The pills, as I'm sure you all know, are taken sublingually. The naloxone is just absorbed barely sublingually, and it's essentially inactive in most people, unless someone tries to inject the pill. And uh, the idea is that then that decreases the risk of misuse, but that's actually pretty controversial. It's not clear that it really does. And for some people, the naloxone is not inactive. And if they tell you they get sick to their stomach, they probably do. It does make some people sick. And then we've got our 2 injectables, Sublocade, which was approved in November 2017. It's a single injection. It lasts 1 month. It must be refrigerated and it hurts. The injection does hurt. And then Brixadi, which Sublocade tried to keep off the market for a long time, but eventually Brixadi was able, through a bunch of lawsuits, they got on the market, approved May 2023. They have multiple doses. Some last week, some a month. It does not require refrigeration and the injection is not as painful. Okay, for sublingual bup, how to administer and prescribe. So I think you all probably know this, but we instruct the patient to abstain. Back in the heroin days, we would say for 12 to 16 hours. If it was like extended release, oxy or whatever, 24 hours, and then methadone or fentanyl, 36 hours. Document mild to moderate withdrawal. When they're in mild to moderate withdrawal, meaning those receptors are empty, start the buprenorphine and titrate up. So how do we know if they're insufficient enough withdrawal? The clinical opioid withdrawal scale, which you can Google, you probably all have it already. And these are just the elements. The ones in red are pupil size, are objective elements. Actually, the resting pulse rate is also objective. Pupil size, runny nose, yawning, and goosebumps. If people have that, they're in withdrawal. They all matter, but those are so easy to track and when they exist. And you generally start when the COWS is about 10 to 12, sometimes when it's 8. For discomfort, Tylenol, and as you're waiting for people to be ready, for the muscle aches, Tylenol and NSAIDs. For anxiety and restlessness, clonidine. Hydroxyzine for anxiety. For sleep, trazodone. I think tizanidine at like higher doses at around 8 milligrams is super helpful for restlessness, or methocarbamol ondansetron for nausea, and then the other meds for diarrhea. We used to give the initial dose as 4. Now, in general, people start at 8 to 16. Because you just know in there at fentanyl that four is not going to be enough. So kind of just start bigger. And if they're going to precipitate with 16, they're going to precipitate with four. So there's just not a real good reason to start with four, but still titrating up. If there is withdrawal shortly after the first dose, you may have precipitated. It's gonna be worse for an hour, up to 1 to 4 hours. If they'll allow it, give more buprenorphine. If you're comfortable, benzos are great. I mean, I used to say, no, my God, we can't use benzos, but they're great. I mean, because so often it's this crazy restlessness, and like 1 or 2 milligrams of Ativan is really helpful.
So just a
Yeah.
quick
Yeah,
question.
please.
If we're starting at 16,
Yeah.
then like isn't the max dose 32? Or is
hmm Yeah,
so
we
there's really not
basically
a lot of space there.
mm-mm. And we just I don't have very many patients who don't need 32. Um, so we will go 16 to 24 or 16 to 32 almost immediately.
So then, like, because I was taught at my clinic, we started on 2 and then like
Mhm.
titrated, and the max was 16. We wouldn't give more than 16. And like, I guess I thought that
Yeah.
16 was normally what induction was, and then 32 would be if like someone continued to have for cravings and was stable, and you kept them at 32 with the idea to down titrate. So are you saying that we should at intake at like our what is it called? At our initiation or whatever, we can go up to 32, and that's like just regular normal practice? Because I don't think that's what it says on like at least even where I trained, where we had our paperwork and things like that, that's where
hmm
we ended up at 16, and that was the max that we would give for induction.
Yeah, I mean, I thank you for bringing that up. We have found that so the community standard, at least currently in Portland and actually in Washington where I've been practicing, really is we just know that people need 32. Sometimes it's 24, but pretty rarely, frankly. So yeah, so we just, and then if somebody comes back and they say I didn't need it, then they didn't need it. But that's not very common for us.
And so then I guess what are the benefits of going up, like that they would keep it? Because if where I was, yeah, we had some fentanyl, but we were still seeing a lot more kind of like hydrocodone and things,
Mm,
and maybe some more heroin. But like with it is going to be uncomfortable. You could stabilize, like are we getting, where is like the significant benefit
that's a
of
great
going up
question.
to 32 so quickly?
And I'm so sorry I don't have them at my fingertips, but a couple studies have found that people are more likely to stay in treatment. If you get them up quickly and onto the higher doses, they stay on it and they come back.
Okay. So it's
Yeah.
a piece of like trying, basically, we are making it as the least uncomfortable for people to come back for treatment. Because, and then my concern is sometimes that I guess I was initially taught that there's that like buprenorphine doesn't necessarily have street value, but it kind of seems like it does.
Yeah.
Um, yeah. And so I guess that's the other concern here of like diversion when it's going up so high, whether or not the patient
Yeah.
absolutely needs it. And how do you assess? I mean, yes, like there's the COWS score and how in withdrawals people are, but how do you assess how much of it is like, hey, this is going to be uncomfortable? Like detoxing is not a comfortable
Mhm.
experience, but versus like, oh, this person really needs it and they're not diverting it, because then you can't really tell, even if you did do a drug test, as a
Mhm.
drug screening.
You're totally right. And it's such a good question. So I'm just going to give you so I am so much less concerned with diversion than with not treating someone sufficiently.
Mhm.
Um, we don't have nearly enough prescribers. So, and we do know that most diverted buprenorphine is used by people to get off of illicit opioids. So I'm just less concerned with it. If somebody really wants to get high, they're not using buprenorphine generally, they're using full agonists, and the research bears that out. So is it optimal to have some of what I'm prescribing being diverted? For sure not. But it is for, again, this is for me. Um, it is the price I'm willing to pay to feel comfortable that the majority of my patients are getting the amount that they need.
Mhm.
But it
And
is, I mean, that's a personal decision.
okay. And then the adverse effects. I know like
Yeah.
we're not really worried about cardiac effects at like the 16 dose or anything, but like I don't normally, because what if someone's needing 32 where I was, I would say like, okay, like at that point you're seeing a tox or you're seeing someone that has trained
Oh,
in this, and I'm like, oh, okay, that's fine. But if someone comes to me and is like, hey, I want 32, I'd say
mhm.
if you're already on it consistently, that's okay. But I don't feel super comfortable starting you on it and then not knowing if you're going to come back.
Mm,
So, and like I wouldn't continue filling it, but like I don't know if first time and
mhm,
then a month later, I don't know where you are.
mhm.
I know that we're not
Yeah.
super concerned about cardiac effects at the lower doses, but if someone's consistently at 32 and
No, I'm
I
not,
have like,
I don't worry about the cardiac effects that really
okay.
with buprenorphine at all. Um, and yeah, and again, the rest is really, part of it is what is your community standard, and it just in Portland and Seattle and like that whole corridor that I have been living on, the standard is really is 32.
Okay.
Um, and so that's what I've become very comfortable with that,
Mhm.
and because of the research that does show the increased engagement and retention, then I've continued it.
Got it.
But I really hear you. Like I think that it's you are prescribing it, and so you need to feel comfortable with the doses you're prescribing.
Yeah.
Yeah.
Thank you.
Yeah. Um, and then again, if you do see precipitated withdrawal, when I first started, and for a long time, I didn't want to give benzos both because it just felt like icky. And I worried about overdose, combining benzodiazepines with buprenorphine. And with induction, I've never, not even close. It's now just something we just do in kind of a standard fashion. If someone is extremely restless, then we know they can tolerate it.
Dr. Gregg, we just have a few
Yeah.
minutes left,
Great.
but I mean, people can stay on if you can and they're interested. I need to do some housekeeping and I'm going to drop an eval in the chat via Alicia. And that way people can ask about other topics, some that came up today for future lessons. I'm also going to put in the warm line for substance use at UCSF, the Clinical Consultation Center. I know they've been really good on Hep C and other topics, but this could be a resource as well that I'll put in the chat.
Great. And I will bomb through micro induction. So the challenge with the regular inductions are discomfort. The low dose inductions are you basically start with tiny doses of buprenorphine and you sneak them on the receptors. So this is one example of it. Um, zero point 0.5 milligram once, and they continue to use their fentanyl or their full agonist. And then the next day, zero point 0.5 milligrams twice. And you just basically sneak the buprenorphine onto the receptor. Um, it's quite comfortable. It is also kind of challenging because if somebody's in the midst of a lot of fentanyl use, they, can be pretty disorganized. And this takes a lot of tracking. And a relatively recent study showed that outcomes are kind of the same, whether you do regular induction or low dose. Um, so it depends on the patient and whether what they want to do and what you're comfortable doing. But you can sneak it on, um, and they can continue to use. That's another way to start. And good patient instructions are helpful. So showing how to get to 0.5 or, depending on how big your tablet or your film is. Um, telling what adjunct meds you're giving and why. And in general, always actually, I instruct patients to take their morning buprenorphine. If they're still using fentanyl, take their bupe in the morning and then before they do anything else. Very close follow-up. If people are having trouble, just slow it down. And of course, everyone gets naloxone. And then this basically just says we're using a lot of 32 milligrams, which we've already discussed. And then I just want to take 2 minutes to talk about the injectables, which everyone, when they were coming out, was like, oh, this is going to be a game changer. And I thought was so irritating. and then they were a game changer. I think they're incredible. So there's Sublocade, there's Brixadi. Again, Sublocade is monthly only. Brixadi is weekly and monthly. Sublocade has 2 doses, 300 and 100. Brixadi has multiple. A Sublocade leaves kind of a big lump. Brixadi does not, and Brixadi does not need to be refrigerated. Sublocade does. I'm not gonna, we can, if there's any questions, we can go through it. But this slide shows the Sublocade dosing. When it first came out, the instructions were 2 doses of 300 and then down to 100. Now a lot of people are just staying on the 300s, which is the equivalent of about 24 milligrams a day. And some people are doing 300s plus supplemental, particularly for the first couple months while the Sublocade is getting to steady state. Brixadi has these multiple doses, weekly and monthly. Initially, there were really complicated ways and like of starting both of them, and now basically both of them say give somebody a 4 milligram dose of sublingual if they tolerate it. You can just give them the shot. And some people aren't even doing the 4 milligram dose. And then there's one more thing called the Brixadi Start, which is kind of cool, that people are just starting to do. And they're using the 24 milligram weekly injection. And that is on this figure, the orange is the peak and the trough of the sublingual. The green is the peak and the trough of the monthly. And the blue is the peak and the troughing of the weekly. And basically, you can see the weekly injection of Brixadi goes up a little more slowly. And as it turns out, it's kind of its own low dose induction. So a couple studies have found that when people come into the ER, this is by D'Onofrio at Yale, they're coming in not in withdrawal or in minimal withdrawal, and they're given Brixadi if they want it. They tolerate it really well, the weekly injection, and they get onto bupe that way. They basically it's a shot that is a low dose induction, and they have very, very little withdrawal. There were a few cases of precipitated withdrawal, mostly with people whose cows were super low. But other than that, it's been quite successful, and we've done it some in Portland as well. It's been really interesting. Okay, so that's it. Medications to treat opioid use disorder save lives. It's gotten trickier to get them started, but it's not too tricky. Long-acting injectables actually are a game changer, and we should prescribe.
Okay.